Hello, and welcome to the Vizient Performance Management Leadership Series. You know, hospitals have been working to improve care transitions and reduce readmissions for years. And Vizient members have gone beyond the conventional approach of focusing efforts just on the Medicare readmissions penalty populations. In the Readmissions Transformation Collaborative, members have focused on all-cause, all-payer readmissions data. And we're going to be talking about this more during our program. I'm Julie Cerise. I'm the Group Senior Vice President of Performance Management and National Networks at Vizient. Today, we're going to take a comprehensive look at how hospitals are participating in the network. They re-examined their readmissions data, they've conducted root cause analysis to improve their high-risk targeting approaches, and they've partnered with community organizations to improve care transitions. So toward the end of the discussion today, you're going to have a chance to join in. Just send us your questions or comments by typing your message in the question box and clicking submit. Also, you can download the educational supplement posted on this web platform. So today's program is really exciting because we're broadcasting not only to our Vizient membership, but also to teams across the country in all of the Hospital Improvement Innovation Networks, or the HINs as we call them. Joining us today, we have two distinguished panelists who have directed this effort with our HIN participants. First, we welcome Dr. Amy Boutwell. Dr. Boutwell, briefly tell us a bit about your background.
Great, thanks, Julie. I'm the president of Collaborative Healthcare Strategies, and I work to advise regional, state, and national efforts to reduce readmissions and promote delivery system transformation. I come to this work as a practicing physician, and as I like to remind teams that I coach and advise, I myself readmit my fair share of patients every time I'm at the hospital. And I understand the clinical challenges and the operational changes that need to be made in order to achieve the aims that we're looking to get. In particular, I developed the Aspire Guide, which has formed the basis of our work here with the Vizient Readmission Transformation Network.
So thanks, Dr. Boutwell. We're so glad you're here. And we also welcome Kelly Goodson. And Kelly, why don't you give us a brief review of your role and responsibilities?
Sure, Julie. Thanks for having me. I'm really excited to be here today. I'm one of the directors of the Vizient HIN. I support a broad range of Vizient teams working on topics that affect many issues that we're dealing with in healthcare today. In the HIN specifically, we produce transformation networks not only on readmissions, as you'll hear today, but on topics such as culture, leadership, and high reliability, as well as person or patient and family engagement and health equity. Those really are my passions, so I'm excited to have this role and to be here with you today.
So thanks, Kelly and Dr. Boutwell. We're so glad you're here with us today. We have the good fortune of having a couple of guests. Later in the program, we're also going to be hearing from leaders at two member organizations who are going to share their experience as part of the network. Ellen Robinson is from Harborview Medical Center in Seattle, and Diane Nano is from University Upstate Hospital in Syracuse, and they will be joining us later today. So Kelly, as a start, describe the Readmissions Transformation Network.
Sure, Julie. So this network launched in March of 2017 with the goal to help our HIN members achieve this all-cause, all-payer readmissions reduction goal of 12% by the end of 2019. We conducted monthly educational webinars to really drive members from awareness into action. We supported them also with monthly office hour calls where they could learn from each other, talk about barriers, lessons learned, interact with our subject matter experts and each other. We, of course, had tools and templates like a project charter, and the Aspire Guide was the foundation of this work, as Dr. Boutwell mentioned. But really, most importantly, to lead this work, we engaged what we called a triad of subject matter experts. So Dr. Boutwell served as our national subject matter expert on the topic. Diane Nano, as Julie mentioned, will be with us later in the show from Upstate University Hospital in Syracuse, New York. She was the leading hospital faculty who brought her knowledge and experience in doing this work to the network. We also found it important to engage the patient and family voice in this work. So we had Patty Skolnick serve as our national patient advisor. Patty formed an organization called Citizens for Patient Safety. She founded this organization after the death of her son due to a medical error. So we really felt it important to bring all these voices into this network to maximize our members' learning and, again, moving them from awareness into action.
Thanks, Kelly. I know you've been involved in this work for quite some time, and we have many members involved as well. So tell us how you support the teams to reduce readmissions.
Well, the program was 9 months long, and through those 9 months, we worked through foundational, core, and advanced concepts, really building as we went through those 9 months. The structure complemented this Aspire Guide, which is evidence-based strategies that really have been field tested and refined, so we knew that they worked. And through Dr. Boutwell, we knew that they worked. By the way, you can find the Aspire Guide on the Agency for Healthcare Research and Quality website. If you simply look on their website, you can find this Aspire Guide. So we had really those 3 elements, foundational, core, and advanced. So let me talk about some of the foundational elements. We took a fresh look at our members' readmissions data, and we used that in order to discover who really were at highest risk for readmissions at their organization. And that helped update their high-risk targeting strategy. Then we had them take inventory of their current readmission reduction efforts. Combining all of those kind of refreshed look at what they're doing determined where their projects should be for those 9 months. And we helped them lay that out and articulate that not only to their teams, but to their leaders. So once they had that down, we went into what we considered a core concept of delivering whole person transitional care, really effectively engaging patients and families as part of the care team. Also examining their risk assessment tools and their scoring of how they looked at their patients at highest risk for readmissions, and helping them work to screen all patients, not just those that they thought were at highest risk. Lastly, the really advanced concepts that are difficult for hospitals to develop and sustain is to collaborate with those cross-continuum partners. Really looking out in the community and discovering who can help them reduce readmissions for their patients, what services are out there, and how they can partner. And then looking internally at how they could enhance their services for those patients that we identified that were at high risk.
That's great. So we know there's a lot of work going on in the country to reduce readmissions and improve care transitions. Dr. Boutwell, what do you think was unique about the Readmissions Transformation Network?
You know, as you said, Julie, hospitals all across the country are working hard to reduce readmissions. What's different now is we're moving into a phase focusing really on all-cause readmissions, all-cause Medicare readmissions, hospital-wide all-cause readmissions. And we need to pivot from our focus that we had, what I'll call in the last phase of readmission work, which was penalty-specific and disease-oriented, to an all-cause strategy. So what was different with this work is that we encouraged that fresh look at the data and to be data informed in order to develop a strategy that can actually get us to reduce all-cause readmissions. This is really a question of numbers, and we've got to look at the math. In a 450-bed hospital, for example, you might have 40,000 discharges a year. If there's an all-cause readmission rate of 12%, that's 4,800 readmissions a year. That boils down to about 12 or 13 readmissions on a daily basis. What we need to do is develop a set of groupings and operational strategies whereby we can actually implement changes in a way that is measurable and effective to serve all of those at-risk patients and thereby bring down all readmissions, not just readmissions for certain pilot populations.
Yeah. those numbers are actually mind-boggling. You know, thanks for putting that into perspective. We don't always think about it that way. That's a huge number of patients being readmitted every year. And when I think about that as an organization, it can be overwhelming, right? All of those patients. How do you go about taking action to address the needs of those patients?
So this is really where the strategic orientation comes from that we worked through in the Transformation Network. What we want to do is develop a data-informed portfolio of strategies. And what I mean by that is organize our work moving away from specific pilot work or disease-oriented work and ask ourselves, how can we organize groups of patients into more broad, robust operational strategies? So we think about that portfolio of strategies in three major components. Number one is really improve the standard transitional care process for all patients. That's all patients leaving our hospital. And that's the quality improvement work that we need to do day to day, understanding what does a better transition out of the hospital look like, whether you're here for cellulitis or whether you're here for heart failure. Second is that we know that patients who are being transitioned from the hospital into post-acute care are at particularly high risk of readmission. We often think that by sending them into skilled nursing care, we're protecting them against readmissions. Not so, says the data. And so we need to develop effective collaborations and what I call co-management strategies to actively manage the transition across settings and have the clarification and communication and collaboration that we need in order to support those patients over 30 days. And then finally, we talk a lot about what else we need to do for the highest risk. That's a very important element of the portfolio of strategies. So we do need to deliver enhanced transitional care services, usually for 30 days, for patients at highest risk of readmission. But really, the way we achieve a hospital-wide readmission aim is by having this portfolio of strategies. And when we break it down like that, Julie, we are talking about actionable, tangible ideas that can work in practice.
So, Dr. Boutwell, here's what I think you're saying. I think you're saying take a fresh look. Look at this from a broader perspective. Don't be so narrowly constrained. Be more thoughtful about what's going to be successful in reducing readmissions.
That's right, Julie. And the exciting thing is this strategy is working for our teams. When we looked at the Transformation Network members who went through the collaborative with us, we saw that those teams improved at a rate nearly double the HIN members who were not part of the Transformation Network. And the exciting thing is that we just refreshed that analysis last night in preparation for this show, and we see that those results are durable and sustained, even though the Transformation Network's over now.
Incredible results. Yeah. Looking forward to hearing how people achieve them. So Kelly, can you give us some examples of how our teams achieved some of that success?
Sure. Our Transformation Network members, many of them actually used our clinical database to do this data analysis and refresh their data to find these patient populations that were at highest risk for readmission. So I want to talk about one particular member who did this analysis and found that the sickle cell population was actually their highest readmitted patient population. This was previously unknown to them. They really were focused again on those Medicare penalty conditions. So once they found sickle cell patients as their highest readmitted patients, they did a root cause analysis and really dove down and looked at their processes and their protocols and discovered they just really needed a radically different plan for these patients. So armed with this information, they were able to present this information to their leadership and redesign care that brought down their readmission rate for all the all-cause, all-payer readmission rate down by 16%.
You know, that reminds me of another team we recently worked with who, again, did their data refresh. And let me tell you the numbers because it really paints a picture. So their overall hospital-wide readmission rate was 13%. That's pretty typical. Then they said, well, what's our overall Medicare readmission rate? 14%. Okay, not surprising. And then they looked at their overall adult non-OB Medicaid readmission rate and were shocked. It was 20%. So their goal is to reduce hospital-wide readmissions, all cause, all payer. And what this three-part first-order data analysis helped them see is if they're going to be successful in reducing hospital-wide readmissions, they need to now start to focus on Medicaid patients and understand the root causes and the needs of that patient population as well. And that's, in fact, exactly what they're doing with us right now.
So in both of the examples, you kind of talked about the deep dive to understand the patients, actually the patients who are coming back into your organization. But now you started to mention the importance of understanding the root causes. So tell us a little bit more about how you help the teams dive deeply into root cause analysis.
I find that really the most powerful way to understand root causes of readmissions is to talk to the patients and their family caregivers. We call this conducting a readmission interview. And what we want to do when we conduct a readmission interview is we want to understand the human, the logistical, the behavior, the healthcare seeking patterns of our patients and their family members. We don't want to over-medicalize the story. Sometimes teams think this is a new task, this is a new burden on their time, but quite the opposite. I do this myself every single time I readmit a patient to my hospital. It only takes opening up a very short type of a conversation where we say, tell me, I see you were recently discharged. Can you tell me a little bit about what happened between the time you were discharged and the point at which today now you or someone else decided you needed to come back again? And you simply open a conversation, you prompt patients to say, you know, and then what, and then what? And you're listening and observing, not just what the facts of the situation were, but you're learning so much about what they understand about their condition, how they solve problems when they encounter a need, who supports them, and ultimately the circumstances under which they or someone else decided they needed to return today. It's not always an acute medical need, that's for sure. Let me give you an example, one of my favorite examples, of a patient that I met 8 days after she had been discharged from my hospital. So she had initially been hospitalized for sepsis, and she was discharged home. She herself had a master's degree, her husband had a PhD, they lived in a house and had transportation and help, and she had 3 or 4 different doctors. So she had access to care and appointments had been made. What had happened was a very human set of circumstances. When I met her in the emergency room, she was so scared. She honestly, in her face and her demeanor, she honestly felt like she was about to die, or that this was the beginning of the end for her, because she knew she had been sick and now she's back again, and it was a very scary experience for her. When I asked her to just tell me, I said, you know, how did you feel on the day you left? And then what happened? And then what happened? What I got was a story of a woman who wanted to go home on the day of discharge. She felt ready. She wanted to get back to her bed and her environment and her family, of course. And what happened day 2, 3, 4 post-discharge was that she just felt wiped out. Well, naturally, she thought, and she went to bed and rested up. But then when she tried to get going again, she found she couldn't get going. She was getting short of breath. She wasn't able to do work around the house. And in fact, she wasn't even feeling well enough to go to that doctor's appointment that had been scheduled for her. So over days, what had happened was she got progressively more short of breath, didn't reach out for help, didn't have anyone come into the home to check on her. Nobody made a phone call to check on her. And unfortunately, it was then on day 8 when she realized she was so uncomfortable she had to come in. So those stories reveal so much about how we need to follow up and monitor and help and support people, because this is a human experience of being sick and trying to recover, and these unlock the stories of how we can really improve transitions and reduce readmissions.
Yeah. And this is my favorite part of the work that we did, because patients and families have so much to tell us. They are the constant in their own experience. I work with a national patient advocate who in his former life was an editor for movies and TV. And he has a saying that I like, an analogy that he uses that I think really kind of paints this picture. So he says to the healthcare team, you see the trailer, I see the movie. So it really sort of helps us understand how much we have to take advantage and listen to our patients and families. They just have so much to add and so much to give, and they should be treated as an equal member of the care team. While we were working through this Readmissions Transformation Network, I mentioned Patty Skolnick was our patient advisor, and she actually had an experience with her husband who went in for some elective surgery, and they were getting ready for discharge, and Patty and her husband didn't really feel ready for discharge. It was on the weekend, unfortunately, and even though Patty knows how to maneuver through a hospital, she knows who to talk to, she knows what to say, no one was listening. And so she even said to them right before her husband was discharged, he will be one of your 30-day readmissions. And they still didn't listen. And shortly thereafter, he came back with a fever. So, we really have to listen to these patients. And as Dr. Boutwell said, we don't need to over-medicalize what's happening. There's so many social, behavioral, and even simple logistical issues that bring patients back that count as our readmissions. And these are really things that we can help with. One of the examples from one of the hospitals in the network was that they discharged a patient. They felt really good about the discharge. She was ready, she understood her medicines, she knew what her next steps were, and so they discharged the patient. Well, shortly thereafter, she comes back and they did the readmissions interview. They used our technique, what Dr. Boutwell just described, and asked, what brought you back? And through this conversation, they realized that when they discharged the patient, her primary caregiver, who was her sister, wasn't there and didn't understand the instructions. And so she actually stopped taking her medication because her sister said that she didn't need to take that medication. So we have to engage patients, families, caregivers in this process in order to truly help us reduce readmissions.
So that interview process really helps you understand what those root causes are. And you mentioned that some of the causes that have been identified through the network and the members' experience in the network have been related to social or behavioral or logistical issues and not just clinical issues. So thoughts about that?
That's exactly right, Julie. And so that gets us to one of the third pillar of the work that we focused on in the Transformation Network, which is once we identify the root causes and the human, the social, logistical elements, we need to match that with an intervention, with services and supports and handoffs and feedback loops that go beyond the walls of the hospital and reach out to providers and service agencies in the community. And this is a real breakthrough for teams when they first are starting to work on readmissions. They really are thinking mostly about the medical paradigm. Are the appointments in place? Are the medications reconciled, for example? And those are important, to be sure. But we have a lot of patients who are being discharged without the services and the handoffs that are needed in order to ensure they are stably transitioned into not just one appointment, but whatever the portfolio of support services they need. A great example of this is the extent to which we're connecting patients, even on our med-surg units, to the behavioral health follow-up that they need. So I was working with a hospital once. They were the one hospital in their entire county region, and they had already established a flourishing cross-continuum team, as we call it. They were working with skilled nursing facilities and medical practices and home health agencies and hospice agencies, and they had basically a beautiful cross-continuum team stood up. So as a best practice site, I asked the readmission champion at this hospital, tell me, what are you doing for your behavioral health patients? And which partners are you working with in the community? And she kind of looked at me and she said, oh my gosh, I can't believe it, but we have no partners on our cross-continuum team that are behavioral health providers. And I said, well, do you know who they would be? She said, you know, I have to be honest, I don't even know where to start. I don't even know who to call. So what we did in that small moment was we just sat down and we Googled behavioral health clinic in the county. We found the largest multi-service clinic in the county area. We just identified who the executive director was, and we picked up the phone and we gave her a call. And honestly, we said who we are and what we were doing. We said we're working to reduce readmissions and improve the connection of our patients to the services they need in the community. We're quite sure that some of our patients would benefit from being connected to you and would really like to strengthen that connection. Would you be interested in working with us? To which she said, absolutely, I would be thrilled. And today, that hospital and that behavioral health clinic have a shared identification system, they case conference, they do warm handoffs, and they feel really great about the connections that they're making for their patients once they leave the hospital.
Yeah. So the third pillar, cross-continuum, community-based partnerships. So I'm sitting on this program and I'm saying to myself, wow, we absolutely need to do that. What would be my first step? Who in the organization would help me begin that conversation to establish relationships with those partners?
The key takeaway that I've learned from seeing literally hundreds of teams take this first step is to keep it at the level of the quality improvement team, the readmission-reduction champion. This might be the director of case management or the director of quality or some other readmission champion at the hospital who's overseeing the work maybe with post-acute partners. The key is to have a pick up the phone relationship with people and to just reach out beyond the four walls of our own organization and invite a new partner to work with us. Time and time again, I find that the answer is we would be thrilled. They've been waiting for the hospital to reach out. The hospital is a leader, it's an authority in the community, and when we reach out beyond our own four walls, people are very responsive. So it's not that hard. I encourage everybody to give it a try as a result of watching this program.
Yeah, and Dr. Boutwell, if you remember, one of our members in the Transformation Network contacted their Salvation Army that was in their community. They worked out a relationship with them where they would hold a certain number of beds per day for the hospital discharges so that they had a place to send their homeless patients that were being discharged. So this helped the hospital really know and understand where the patient is to be able to provide some follow-up services for them and help further make connections with community partners to prevent readmissions, and not only prevent readmissions, but help reduce the length of stay by having this safe place for them to be discharged.
So really great examples from both of you. Thank you so much. Kelly, you have the opportunity of participating as a network leader, and so you get to hear the experiences of all of the members in the network. So could you maybe give us some of the key takeaways that you've heard from this entire network experience?
Sure. And I'll actually share the words directly from our members. So we talked about sort of the three main facets of this work. So let me start with the data analysis, taking that fresh look at the data. They talked about that data analytics can discover hidden patient care opportunities. So things that weren't on their radar, that they were not aware of, it helped discover those opportunities for improvement. a lot of them talked about the LACE tool, the readmission risk LACE tool that's been very popular, that it didn't really work for them. So they used their own data to identify which patients were really most at risk. And some had big surprises. One was particularly surprised about the age of their frequently readmitted patients. They were younger adults that actually had multiple issues that brought them back to the hospital. So when we talk about root causes, having that right tool to assess these root causes of readmission was key to their success. And we're really speaking about that patient readmission interview. So many learnings, so many ahas from that work. We could go on and about that. They also learned that they just cannot focus on disease only. You have to look at that whole person transitional care, like we've been talking about. And then developing that portfolio of strategies and those cross-continuum partnerships. One member noted that it helped them develop this systematic targeting approach in regards to that care transitions that actually helped all patients, not just those at highest risk. And it helped them really have the confidence to develop these partnerships and these relationships with those community organizations. And again, that was a key to success.
So there's been a lot of work in the Readmissions Transformation Network, great results. We have some incredible learnings. Now, how are we getting that information out beyond the experience of just the network participants? How are we sharing it?
Yes, great questions. So we've actually already started to share and spread this work. So we created a playbook. Dr. Boutwell, Diane Nano, Patty Skolnick helped us create this playbook. And we have disseminated that and actually used it as the foundation for a really popular collaborative focused on ambulatory and post-acute care issues for readmissions that's currently underway. I think it ends in November. The playbook actually is downloadable from the documents section of your viewing screen. So now you have access to this playbook. So you can see exactly what we did in the Transformation Network. There's links in there to past recordings that you can use in your work. So in 2018, we really evolved that Readmissions Transformation Network into one that we called the Vulnerable Populations Transformation Network. We wanted to build upon what we had and dig deeper into this work. So we worked with some of the same members, but also brought in new members who really could use that playbook and the education and tools within it to kind of get caught up. And we kept the elements that really the network participants felt worked, and then added an element of one-on-one coaching with Dr. Boutwell that was really effective.
So lots of information here, a great model, a great approach. We are so fortunate now. We have 2 participating organizations on the phone, and they're going to be sharing with us their experience and what they've learned as part of the Readmissions Transformation Network. So first, we have Ellen Robinson from Harborview Medical Center in Seattle. So Ellen, can you tell us a little bit about your background and your role at Harborview?
Sure. Thanks, Julie. I've been up at Harborview for more than 20 years, originally as a physical therapist, working in our ICU and acute care areas, and more recently as a clinical quality analyst. And currently in that role, I provide project management support to our operational teams, as well as providing data and data analysis to help them get their clinical improvement projects moving forward.
Thanks so much, Ellen. We also have with us Diane Nano. She's from Upstate University Hospital in Syracuse, New York. So Diane, tell us a little bit about your background and your role at the hospital.
Thanks so much, Julie. So I am a clinical nurse specialist with a concentration in transitional care. My background is in certified home care, and what I really noticed while I was doing home care was, we could do this so much better. So I decided to go back to the hospital setting as a transitions coach. So I practiced as a transition coach with Eric Holman's model. and we were really able to really show some great outcomes with the transition coaching that was really extending the care that the hospital was giving in the home. From there, I came to Upstate University Hospital, where I am now, and what we did was pull all of our transitional care services together under one umbrella. So I oversee our case management department, social work, interpretive services, our enhanced services, the relationships with our post-acute partners, heart failure team, and our multi-visit patient management.
So Ellen, let's start with your organization. So explain your involvement in the Readmission Transformation Network and tell us a little bit about why your organization chose to participate.
Sure. Harborview has participated with a lot of different collaboratives with Vizient over the years, and what we found is our participation really enhances and accelerates either new or ongoing clinical work by providing a structure to the project, some accountability and deadlines for reporting, and then most importantly, some subject matter expertise. So we really found that these networks allow us to increase our engagement across the enterprise around a specific topic or problem that we've been struggling with.
So then tell us a little bit more about what you specifically focused on in the initiative to really improve readmissions and transitions.
As the only safety net hospital in Seattle, we know that we have a high-risk, vulnerable population just as our mission. So using the Aspire tool that was mentioned earlier, what we realized is we were really going to have to focus on adults with Medicaid as their primary payer. We also realized that housing insecurity was a large impact for our patients, as well as patients who had a behavioral health comorbidity, both on a mental health disease processes and substance use disorder. So that really became our population of focus.
And what did you learn, and how did you address the needs of those patients then?
Well, again, as part of the collaborative, we really worked to create a driver diagram that would help us lay out all the interventions that were going on across. After completing that root cause analysis, we were able to kind of structure some of those findings into themes. So one of the first themes really had to do with communication. So the state of Washington has a system across their emergency rooms where you can find care plans from other emergency rooms when patients are frequently going to emergency rooms across the state. But we found it wasn't always visible to the frontline providers. So we really worked on getting those patient care plans into a place where people could use them and make action plans around them. We also found opportunities to improve our communication with our nursing home partners and our primary care providers to ensure smooth transitions from inpatient to outpatient. Another theme that we found really had to do with early identification of what our patients need. We had to recognize the risks of our inpatients, so we used a vulnerability screening to assess their social determinants of health and then work to connect patients with those services that they needed, be it a housing issue. We provide brief interventions during the inpatient stay for substance use disorder and a variety of other community resources. And I think the last theme really was around chronic disease management. We noticed that some of our patients with renal failure, COPD, were having high risks of readmission and utilization. So we started with a case manager for our COPD population, as well as partnering with our dialysis centers in the community. Overall, just providing a bridge to ambulatory care that really worked for each patient's specific needs.
Wow, that's really great. You've given us a lot about how you've detailed the very specific patients that you had to address and then all of the interventions around supporting those patients. So tell us a little bit about the experience. So what was helpful about the structure of the Transformation Network?
You know, the Transformation Network format that now includes an informational webinar and office hours once a month, as well as a one-on-one coaching session, was really useful, this transformation. So typically we will listen to the informational sessions together as a team, or just one or two of us will listen and bring back those learnings to our ongoing team meetings. The coaching calls were really beneficial. What I did was work through each month assigning different operational leaders that time so that they could come forward with specific questions around the barriers they were encountering and get suggestions from the subject matter experts about how to move the projects forward. I think the other really beneficial piece of the Transformation Network was the focus on a patient-centered intervention. There were many videos that were shared telling patient stories from across the country that we found to be very powerful and really kept our clinical staff engaged in the project.
So Diane, let's turn to you now. I understand that you're one of the leaders in the Transformation Network, and your team and organization participated as well. So give us some understanding of why you chose to participate in the network.
Sure. So first of all, I have to say that we have had the great privilege of working with Dr. Boutwell for quite a while. So that in itself is a pull, I have to tell you. And we've been on this journey for a while around improving our transitional care, reducing our readmissions while we have an eye on length of stay and all those things that hospitals have to look at. But our goal was really to continue our work with best practice, evidence-based transitional care for all, but really make sure that we're addressing specific populations that maybe need some enhanced care. So we have multiple enhanced programs that are around multi-visit patients. Some are disease-specific. We've really expanded them out to include social determinants and housing and working with payers and working with post-acute partners. But we really felt as if we might have been missing some populations. So what was important to us was, because we had participated in networks before, is that we wanted to learn from other organizations about what worked and maybe sometimes more importantly, what didn't work, to understand to increase our understanding of those clinical and social opportunities to decrease potentially preventable readmissions and overutilization overall. So that was really why we chose to go ahead with the project.
So I so appreciate the point you just made about the experience of the network, learning what worked, but also learning what didn't work, or maybe not what didn't work, but how you need to amplify certain dimensions or aspects of an intervention so that you can ensure its success. So thank you for that. As a leading faculty member, I'd be interested in understanding what you think are the key breakthrough ideas or approaches that have helped you get results and that have been highlighted in the network as well.
Sure. So number one, it's comforting and encouraging to know that you're not alone in the challenges, especially with particular patients. I think Kelly mentioned the sickle cell population. That's certainly a challenge for us. And actually, even though it's a lower volume, it's our highest incidence of readmission in a population. So that was important for us to learn, to learn a little bit more about that. And again, it's helpful to learn about barriers and how they were overcome. The monthly calls were really helpful. The learnings, the one-on-one coaching was really helpful, and just making sure that we're collaborating with other organizations. And it's interesting because some of those relationships are ongoing beyond the time of the collaborative.
So thank you so much. So I'm really excited. We're getting lots of calls and lots of questions, so we want to be able to get there. So Diane, I know that one of the dimensions of this work is understanding your population, right? Who are your patients that are returning to your organization? So was there anything unique or surprise that surfaced for you as you were doing that exploration?
So great question. We have, as I mentioned, multiple enhanced services. We're very fortunate to be able to really develop whole person programs. When we looked at our data, and Dr. Boutwell mentioned data-informed portfolio of strategies for specific populations, we looked at our data in a new way. So, Dr. Boutwell also talks about renewing and refreshing. So sometimes a challenge for us, because we have all these programs, is to really identify different populations that we might be able to serve. So our fresh look was, we knew that sepsis was a high readmission diagnosis for us, but we really didn't realize how significant it was until we really drilled down to the data. Additionally, once we saw the readmission rate for those patients and how soon they were coming back, we drilled down a little bit further and into where they came from. So many of these patients were going to skilled nursing facilities. Some of them were going to home with home care, and some of them were going home without services. So it was important for us to know where patients were going and why they were coming back. Number one, to understand the reason, but also to understand who our partners needed to be to really look at the problem. In addition, what we also, when we dug down a little further to the data, one thing that was really surprising, but then looking at the national data probably shouldn't have been, is that the mortality rate for these patients 30 days after their return admission was very high. About half of those patients actually died. So we knew that we had to bring in the palliative care hospice partners to look at them. And the other thing that was surprising was that many of these patients also had active cancer diagnoses. So when we looked at what we might be able to do about these patients, what's important is that before you sort of jump into an intervention, you understand the problem. So we pulled in those post-acute partners, so skilled nursing facilities, home care. We actually have a transitional care unit within our own organization. So we're really looking at patients who are eligible to go to the TCU, to go there for an amount of time to be sure that they're stable enough, that we've got the services in place, that the education is being done, and that if their clinical care needs to be tweaked, it's tweaked. So that was really a really important surprise, and it was actionable at the same time.
Thanks so much. So Ellen, I'm going to circle back to you. I want to ask you, what do you feel you've accomplished as a result of your time in the network?
Well, I think the biggest thing has been that we really has allowed us to develop best practices around readmission reduction and care transitions. Our two inpatient and ambulatory teams are really working kind of in silos, and this provided us with a framework to develop our team and coordinate our projects across both settings. It also really has allowed us to highlight the importance of this work for our executive leadership. I think what's also been exciting is we've actually seen a decrease in our readmissions across both of our Medicaid and Medicare populations, which has really impacted our overall reduction, all-cause readmissions, from 11% down to 9.6% for the last fiscal year. And when you guys were mentioning the numbers earlier in the session, what I realized is that's 250 patients this year that did not have a readmission in our population. So that's been exciting. The other thing that has improved was our ability to capture our patients' housing status, and we're now able to measure outcomes for patients with housing insecurity. We see that readmission rate for that population is double that of patients who don't have housing issues, and we're really using this data to discuss the impact of homelessness in our community when our executive leadership meet with people from the county and other external agencies.
Thanks so much, Ellen. And Ellen and Diane, thank you for giving us such valuable insights and sharing the lessons that you've learned across your journey to reduce readmissions. So Ellen and Diane are going to remain on the phone for your questions. Now, before we go further, let's get you involved in the conversation. Share with us online. So just type your question or comment in the Ask a Question window and click Submit. And while we're waiting for questions to come in, let's ask Kelly, what's next for the work?
Yes, well, as I mentioned before, our work has evolved. We're really leveraging what we've learned in the transformation networks to address this all-cause, all-payer readmissions, working hard to identify those vulnerable populations that are at highest risk of readmission to your individual facility. So we're turning our attention to a very important subgroup, high utilizers, or as Dr. Boutwell likes to call them, MVPs. So Dr. Boutwell, tell us briefly about what is an MVP and what is the method we're going to use in our next transformation network.
Thanks, Kelly. So multi-visit patients, or MVPs, are patients, of course, who are admitted frequently in a 12-month period. This is the small percentage of patients who are in the hospital a lot. But not only that, when we look at our data, we see this is about the 5 or 7% of our hospitalized population who's accounting for over 50% of our 30-day readmissions. So far in the field, we really haven't felt like we've had a set of tools or approaches to effectively serve these patients' needs. One thing that we hear from teams across the network is that, we run down a good transitional care, we try to give the best care we can, but this group of patients seems to be coming back no matter what we do. Well, the good news is, over the past 3 or 4 years, there has been a lot of really good work happening in the country to really dig into how to understand this group of patients and how to improve their care to slow that cycle of high utilization. And so that method is called the MVP method, and we're going to be delivering, starting next week, October 1st, really, we're going to be delivering the MVP Acceleration Network to help teams implement the MVP method in their own setting with their own patients.
So thank you so much. We have a number of questions, so let's jump into this. So the first question is around focusing on high utilizers and whether that makes a difference. Isn't there an issue with regression to the mean? Okay, so this is a complicated question, but I guess the question is really about the decision to focus on high utilizers as you're talking about MVP.
Yeah, absolutely. And so there's no question that there has been a prevailing wisdom in the field that says since last year's high utilizers, MVPs, are are often no longer this year's MVPs, let's just ignore them. That's not working. It's not working for you. It's not working for your readmission rates. It's not working for anybody. And so what I've had the good fortune to do is to lean straight into who are today's MVPs. Just like we already know they're high risk of readmission, we know they're high risk of coming back over and over again until we slow that cycle. So that's part of the MVP method. And then really the question around regression to the mean is a measurement question. And the MVP method has developed a specific measurement strategy to understand the relative impact of working on today's MVPs to reassure and demonstrate to us that we are in fact making an improvement. We're slowing the cycle faster than we would have done if we did nothing. And that's really the concern that I have, is that we are currently allowing ourselves to do nothing for this group of patients who clearly have the greatest needs, and they need us to actually do the most.
Yeah. So, we know that some of the issues associated with care transitions and readmissions have to do with social, behavioral, and logistical reasons that patients are actually returning. And there's two questions here. One is really about, not having the resources to address those issues. And then there's a second question about patient and family engagement. So I'm trying to kind of get your thoughts about those 2 points of view and how do we utilize patients and family, and how do we address the needs that are not necessarily clinical needs.
Mm-hmm. Well, I'll start with that one. Patient and family engagement is really an important approach to healthcare transformation. I mean, we need to think of it as a strategy. It is something that can help us in ways that we can't even imagine right now. As I said before, patients and families see the movie, we only see the trailer, and oftentimes they have solutions to offer that are quite simple and oftentimes do not cost any money. So we really need to open up those dialogues, as Dr. Boutwell talked about, ask about why they were readmitted, look at those themes and patterns and see what can we do, because you can do something. There is something you can do to help those patients, and ultimately it will help you and your organization reduce readmissions and improve your bottom line.
And here's a real conceptual frame shift that teams would be well advised to really think about. Oftentimes we think, oh, patients have social needs and behavioral needs and clinical needs, and they have needs for services and supports, et cetera, and that sounds like it's very expensive. It's a lot of needs. But one thing that I know that Diane and her team at Upstate have really leveraged, and perhaps we can hear from Diane, is making sure that we're assessing for those needs, and then we have the relationships in the community to connect people to the services they already have. See, so many readmission reduction teams think that if I'm going to address a broader set of needs in order to reduce readmissions, then I need to pay for it or resource that. And that's not the way to think about it. The way to think about it is to really make sure that you're building those working relationships with the organizations and agencies that already exist. And that gets you breakthrough results.
Yeah. So Diane, I'm just curious if you have thoughts on this, because these issues, social, behavioral, logistical, these are real issues. How do you do this? How do you address these issues in an economic way? Everybody's looking for the economics around this.
No question. So thanks, Dr. Boutwell. That's a huge point. So a couple of very, very simple, just almost silly things that we've done with our post-acute partners is they used to be called vendors that came into our hospital like they're trying to sell something. We changed the name to post-acute partners and gave them space in the hospital. We identified specific key stakeholders that are already working with these patients. So on the behavioral health side, shelters, community care management agencies, really anybody who's working with these patients, skilled nursing facilities, home health agencies, payers. The good news about all of this is that our incentives are all aligning now. They weren't always, but they are now. So certainly it's to the payers' benefit to do care management stuff with our patients post-acute, to reduce readmissions to the hospital and ED utilization as well. Same with community care management. Same with really any post-acute partner that is taking care of these patients. So we invited them in. We give them space. They're actually in the same space as my department, and we really have a great working relationship with these folks.
And Julie, I'd like to add one more thing to that question. When we talk about the economics, teams can get really frustrated with these high utilizer patients, populations. Dr. Boutwell talked about, non-compliant and things like that. Well, when you really dig down and get these root causes, you can help the patient, but you can also help your care team. They can see actual strategies and tactics that are working to reduce readmission and make life better for these patients. That's why we all got into healthcare, was to help people. And I think the frustration comes from not being able to help. So when you employ some of these strategies, you really help your team lower their frustration and bring that joy back into work that we're all really concerned about right now.
Thanks so much. So thanks, Kelly and Dr. Boutwell. We are at the end of our program, and I want to thank you both for joining us. There are several questions here, and I'm just going to make a couple of points. People are asking about a sickle cell readmission plan. They're asking about a transition coach plan. They're asking about an interview guide or script. We have all of these things, so we will post them and they'll be available to you. Another question was just about the MVP Collaborative and when is that starting? That's starting in October. I suggest you reach out to Kelly Goodson, who can give you more information on that. So thanks to you, our viewers, and for taking time out of your busy schedule to join us. Our next program will be on Friday, December 14th in the same time slot, and our focus will be on the work in the ambulatory area. So a continuation of this conversation, how to help members prepare for value-based care. So you're not going to want to miss that one. We'll see you then. Now from Vizient, I'm Julie Cerise, and thank you for watching.